Welcome everybody. Thank you so much for joining us today for our March webinar for the ACPRO New Practitioner Committee. We're honored today to have Dr. Anthony Chang from BAMF Health discuss clinical experience of PSMA, molecular imaging, and molecular targeted radiation therapy on prostate cancer. Dr. Chang is the CEO and founder of BAMF Health, which is a advanced cyclotron-equipped radiopharmacy and molecular imaging clinic that is set to open in 2022 in Grand Rapids, Michigan. This clinic will be home to never before seen theranostics in the treatment for cancer patients and patients suffering from various other disorders like neurodegenerative disease. Potential cancer applications will include prostate, neuroendocrine, breast, pancreas, lung, gynecologic, colon, and brain cancers. And BAMF will also be focusing on diagnostic and therapeutic applications in pediatric oncology, Alzheimer's, Parkinson's, endometriosis, chronic pain, PTSD, and depression. Dr. Chang got his PhD in medical physics with a specialization in diagnostic imaging physics from the University of Texas Science Center at San Antonio, and has had several accolades, including the Grand Rapids Business Journal 40 Under 40, amongst others. And we're very honored to have him speak to us today. Dr. Chang.
Thank you, Brandon. It's my great pleasure to be here to share our passion and experience on PSMA. In today's talk, this is the agenda of today's lecture. In this talk, I don't want to try to jump into traditional academic talk to just make a lecture report, talk about the paper has been published and all the data. I think BAMF Health has a very unique asset, which is we have jumped into the PSMA theranostic for almost 5 years right now, and our chief medical officer, Professor Richard Bong, considers one of the pioneer in the whole theranostic field. He's one of the very first persons start the PSMA theranostic treatment. Therefore, we actually have a lot of very unique experience and the patient data I want to share with you. To date, we have treated over 2,000 rounds of the PSMA theranostic treatment, combining both alpha and beta. And we're one of the leading group in the world using actinium to treat prostate cancer too. So today, I'm going to basically introduce the concept about what evidence-based medicine is and why we need to jump into intelligence-based medicine and why molecular imaging and theranostic will be very, very important, and share our unique experience about PSMA theranostic in our clinic, and talk about the future, what the future will look like. And hopefully after this meeting, will start triggering a lot of people start thinking about what we can do with these new weapons in our back rooms and how we can serve the patients better. So the first we can talk about what is evidence-based medicine we currently practice versus what we need to achieve intelligence-based precision medicine. So the problem with current practice, if you think deeply, is that we're constantly start using past information to treat patients in present. I mean, especially in oncology, a lot of time the reason we use to decide how to treat the patient right now is the CT, MR, or the pathological data a few months ago, even years ago. And constantly we're using morphology to decide the biology. From CT, MR, from pathology, we constantly say, hey, this shape doesn't look good, so I think it's malignance, and this is something shouldn't be there, is there, and that's could be a tumor. But what's the molecular composition of that lesions? What's the biology of that lesion? We have no idea. And we also constantly treat the patient as part of statistics. That's how we practice. Currently, we practice medicine right now. We use evidence-based medicine, make evidence-based guess. But is the patient belong to, is this patient belong to this 40% that will respond to this kind of treatment, or the other 60% will not respond? We don't know. So constantly we need to do trial and error method to find the right treatment for the patients. And the result is we waste about like $200 billion a year on unnecessary procedures. So everybody knows we need to start to achieve precision medicine. What is precision medicine? It means we need to offer the right patient the right diagnosis and offer him the right treatment, the right treatment at the right dose at the right time. And ideally, we want to use the most current present information to treat the patients right in front of us. And we want to use biology to decide the biology. And we want to treat the patient as a person instead of part of a statistic. And that's why we need to achieve intelligence-based precision medicine. We can treat the patient with confidence. So what is intelligence-based medicine means? Meaning we need to start to acquire the right information first and turn this right information into useful intelligence. And constantly right now, especially for cancer treatment, we are trying to acquire a lot of information, help us to make the right decision. But all the information, common information and the tests we are doing actually they all have some drawbacks. For example, conventional CT MR can only see the lesions until the lesion achieved to a certain size. Lab data, genomic information, they can tell you yes or no question, but it will never answer you how many tumors are there, where are they, and those are the critical information for us to decide how to treat the patients. And biopsy, yes, it can give us a molecular profile of that specific tumor, but everybody knows the tumor is heterogeneous. So the tumor with biopsy may be very, very different from the tumor metastasized to distant locations. Therefore, molecular, and also once we start treating the patient, how did the patient respond to this kind of treatment? How can we know if this treatment will work before the tumor started shrinking? That's why to be able to see the molecular information, acquire molecular information and the location information from the patients is very critical. And today, molecular imaging looks like it's going to be the most efficient and useful technology allowed us to do that. So what is molecular imaging? Molecular imaging is actually a non-invasive technology allowed us to monitor molecular activities in the patient. And the majority of the time, we are actually talking about molecular imaging, talking about a PET or SPECT or optical images. But the most common and the practical method to apply to clinic to the patients is going to be PET. So today I'm going to focus on PET. And the PET is also not only can offer a molecular activity information to the patients, the molecular profile, it can also offer us the geographic information of the patient's disease. And besides that, PET is considered as a quantitative technology. So we can get a quantitative data from instead of just a qualitative data from this technology. So how does PET work? Literally, we need to create a lot of different kind of tracers to looking for different kind of disease. Say if there's a tumor over there, there's a special target over there, and it's only very specific to that tumor. So we can create something called tracer, and the front part of the tracer is a ligand. Ligand is like a key trying looking for those kind of target, and we tag this ligand with a positron emitters with different kind of half-life for different kind of purpose, and inject this tracer to the patient's body. Then we can start to it will circulate over body. Once they find the target, will bind to it, send out signal, and we can put patient into the PET scanner, and we can know where the cancers are and how many are there and how many targets are there, how many molecular targets are there. So with this basic concept, let's take a look about the application specifically to PSMA. So prostate cancer has always caused is one of the most common cancer in the world, but we don't really have the significant improvement for past 20, 30 years. We have a better hormone drugs, we have better chemo drugs, we have better external beam radiation machines who can shoot more accurately. But the biggest hassle still, it's hard to see where the tumors are. And especially for a patient with a low PSA. PSA is pretty much the only standard we're using to decide if the patient cancer coming back, does the patient has prostate cancer or does the treatment work? So when PSA PET tracer coming out to the market, 4 or 5 years ago, when we start doing a lot of clinical trial in Germany, and we see significant improvement on early diagnosis and help on decision making. So with PSMA, it will allow us to see where tumors are, both like a small and big tumors, and also allow us to see the tumors in the bone and soft tissues. And we can also identify this tumor the tumor has the PSMA expression. If it has PSMA expression, then we can use PSMA radionuclide treatment and to treat it and to achieve complete remission with no toxicities. So let's take a closer look on that. So what is PSMA? PSMA stands for prostate-specific membrane antigen. And 90 to 95% of prostate cancer cells express a certain level of PSMA. And the PSMA expression will increase when the tumor grade increase. And if it start to be more aggressive, start have metastatic disease, become a metastatic disease, PSMA of prostate cancer will increase. And the PSMA also is, but PSMA is not specifically only located in prostate cancer. It also expressed on other certain type of cancer, but it's not consistent. And a majority of a cancer, we can see the PSMA expression, but those kind of PSMA expression is not inside or on the cancer cells. It's actually on the neovascular structures around the tumors. So PSMA can be a very good tracers to detect other type of cancers, but because it's not located on the cancer cells, and it may not be a good target for treat other type of cancers. This is just some pathology information about a PSMA, and there's a lot of organs actually express PSMA. In the brain, we have RNA expression, but not too many protein expression. GI tract, we see a lot of expression of PSMA, and kidney, we see the expression of PSMA, and the majority of PSMA is actually expressed in the prostate and the salivary gland tissues. This is just shows some information about how does PSMA images looks like. If you try to tag PSMA with positron emitters, and that these PSMA will automatically go to these background organs. We talk about the tear gland, the salivary gland, kidney, because it has expression, but also the tracer is excreted through the urinary system, and the intestine has expression. So we can see intestine or GI tract as background organs. And when you have a prostate cancer, then you can start to see the prostate cancer very clearly. And that's just show you some example of PSMA we see in clinic. PSMA allowed us to see a very, very small lesions based on our experience. And it's a one-stop shop. Conventionally, we need to do MR, we need to do CT, we need to do bone scan in order to stage the patient correctly. But we can actually use PSMA. It's a one-stop shop. We can see the bone lesion, soft tissue lesion very well, and we also can see lesions from as small as 2 millimeter size. And this is just an example of one of our patients with PSA 0.37, and we can see the soft tissue metastasis, and we also can see the bone lesions through the PSMA PET images. And sometimes when we're looking for bone scan, CT can see the lesion. PSMA will show PET image. PSMA PET can see it too, but sometimes it is more sensitive than CT. Like this patient we have on the CT we cannot see any bone metastasis, but PSMA image clear identify there's a bone lesions over there. And this is just show you some PSMA in detecting the bone marrow metastasis from our clinical data over there. So to the end, PSMA is a one-stop shop, very, very sensitive, especially helpful on low PSA levels. I mean, it's not 100%, but for PSMA, for PSA under 0.5, between 0.2 to 2.5, we still have around 50% chance we're going to detect lesions. So this helps us solve a lot of problems we're encountering right now. If a lot of time, if we have a recurrent prostate cancer patients, we see the PSA start rising, but it's not high enough to identify where the tumors are and confirm the tumor is coming back. And so pretty much we offer a patient like a 3 method. Number one, we can do the salvage radiation, even we cannot see where the tumors are, or we can do some chemo hormone therapy and just hopefully we can hit the tumors. Or the third method is ask the patient to go home to do the sit and watch method. And if you are patients, those are none of these methods are the good method for these for the patients. But with PSMA, we can start changing again. This is one of our patients from Grand Rapids. Gleason 9 has a radical prostatectomy, has received the salvage radiation therapy already, but PSA started to keep rising. So right now, at least this phase, he received multiple CT, multiple MRI, still cannot locate where the tumors are. And then so we give him, we bring him the PSMA PET images. So automatically we actually find that there's a 4 lymph node metastasis in mediastinum area. To the end, he said his cancer is actually not located in the prostate area or close to the pelvic area. It's actually located in the chest, and that's a very interesting finding we constantly experience in our clinic. As we started to realize a lot of early phase metastases, especially biochemical recurrence prostate cancer, intended to go to the a chest area instead to stay in the pelvic area, what we used to think it should be. So that's a very interesting information after we have these powerful tools. And this is just another patient we want to share with you. Gleason 9 has prostatectomy and PSA started rising, but still very, very low, 0.37. And based on the current European guideline, this patient was suggested to receive salvage radiation. But we also know a lot of over 50% of salvage radiation, a patient received salvage radiation will have experience the recurrence. So this may be the reason why we did the PSMA images to this patient, and we actually identified there's over 20 micrometastases in these patients, and majority of the patients is outside of the pelvic areas. So, I mean, not only for this patient, the PSMA PET image not only prevent him from unnecessary salvage radiation therapy, but this can also prevent him from unnecessary potential a side effect from the salvage radiation. And if we think deeper, and maybe the reason the patient have a recurrence after salvage radiation is not because salvage radiation doesn't work. Is when we treat it, a lot of tumor has left the pelvic area already. This is just some summary from the journal, different kind of papers about the detection rate of PSMA images. Every paper has using different kind of PSMA type of tracer, for example, PSMA 11, DCF pile, etc., etc. And they also have different kind of method, but constantly they all show very, very promising detection rate compared to the current best method over here. And as long as you, especially you can see when PSA over 1, the detection rate is very, very high. This is just another paper trying to talk about, several papers talk about combined imaging modalities to make an early diagnosis using PSMA PET imaging to make an early diagnosis of the prostate cancer. The current method to make a primary diagnosis is using the MRI, and the sensitivity is about 66%. PSMA is 92% from this study, and if you combine PET and MRI together, it will achieve 98%. And the very interesting thing is, remember we talk about when when you're trying to, we can actually, when you're trying to suppress androgen, it actually gonna boost the PSMA expression. That's what we observed in the clinic, and there's several paper has been published to all the way from the preclinical study and to prove the mechanism and pathway of this observation to verification in clinic. And so this is a paper shows a patient receive ADT, and after receive ADT, the PSMA start expression going up. So that's why we need to start be very, very careful about it. I mean, sometimes if we see more lesions on the PSMA PET imaging, it's not purely because the tumor is really progress. Maybe it's just because like a patient receiving new treatment, so we can have a higher PSMA expression, and we can see more tumor right now. But to take advantage of this kind of biology process in the future, I think there's maybe we need to do more research in to think about it. Can we use a minor dose of androgen deprivation therapy to boost the PSMA expression, allowed us to see more tumors, so we can stage the patient more correctly. And because there's more expression, it will allow us to load more radiation to each tumors to get a better control of the tumors. This is just some of the clinical study to make those efforts I just mentioned over there, and it's going to be a very hot field, and that's going to be very, very promising and exciting for the futures. If we can have a more boost the PSMA expression of prostate cancer using the drugs, then we can see more tumors and we can load more radiation, so we can have theoretically we can have better control. So conclusion about the PSMA PET images is PSMA expression over at least 80% or even 90-95% prostate cancer cells, and it has 100 to 1,000 times higher expression than normal prostate tissue. So it makes a very, very good target to see. And PSMA level increase with the ADT, and also the PSMA is actually endocyte PSA binding to the ligand binding to the PSMA protein will induce the endocytosis. So the whole tracer will be bring into the cell, so it will improve the retention, and it will improve the signals, and also we can retain the treatment. So which make these things combined make PSMA a very, very promising target for both diagnosis and therapy. And the background organ to know just salivary gland, anterior gland, kidney, small intestine, and potential. Be careful about brain, but the current PSMA target molecule doesn't cross the blood-brain barrier, so we don't need to worry about that. Okay, then we get into the more exciting part right now. I mean, once we can see more tumors, then when we need a more efficient way to treat it. The common problem right now for prostate cancer treatment is not about oligometastasis. If we have a limited number of tumors, there are so many ways we can treat it. The external beam radiation and the IMRT, SBRT, there's so many ways we can precisely target tumor and eliminate it out. The real problem is once we have hundreds of small metastases and we need to do systemic treatment, then how are we going to do that? And chemo, we all know chemo hormone will eventually almost guaranteed to treat achieve will induce the resistance, and also a lot of unwanted side effect. So if we can combine the power of radiation and the systemic philosophy of systemic treatment, then theoretically we can have better control of these kind of treatment, these kind of patients. So let's take a look about how we do it. And we're using very, very similar concept of the diagnostic tracer. But right now, we just swap the camera or PET diagnostic isotope into a therapeutic isotope. We later start to load the atomic bomb with the tracer and send it into the cancer cell. And once it uptake to it and burn the cancer cell out. And because we are directly trying to send the radioisotope into the patient, try to load the radiation to where the tumors are, the radioisotope we're choosing is usually we want to use alpha beta particle. Why is that? Is because those are the particle can have a very, very high LET. So meaning they will basically deposit a majority of the energy it carries in a very, very short distance. So that means if we can directly deliver this radiation to where the cancer cells are, we can deposit a huge amount of radiation to kill the cancer cells, but without hurting surrounding tissues. The advantage of this kind of method is, number one, it's systemic. So we shoot it into the body and it will automatically find where the tumors are and we'll try to burn it out. But it's targeted, and because of the property of these radiations, we have a limited damage or no collateral damage to the surrounding tissues. And because this kind of treatment is a little bit different from the external beam radiation concept, once it binding to it, it will stay on the cancer cell, keep it radiated 24/7 until it decayed or being degraded by biological mechanisms. So it can deliver a lot of radiation dose to each tumors over there. So let's start from one of the most popular treatment on the market right now. And I have to say, even I say on the market, is still in clinical trials. It's called lutetium. It's a beta emitters. And the range of this radiation is about 25 millimeters, so it's about 125 cells. So meaning, if we deliver this isotope direct to the cancer cells, it will pretty much damage everything about 125 cells range. And the good things about lutetium-177, besides it is a beta emitters, it also emits gamma. So it allows us to see where the isotope goes, and we can use this property to do the dosimetry analysis. And right now, based on our study and a lot of published data for the past 4 or 5 years, we can everybody agree this is a very safe method. We don't see any like a renal, hematopoietic, and the liver toxicity. And some people we may see minor dry mouth from some patients has been bombarded by chemo and hormone therapy, but not very common for relatively healthier patients. So this is some of our results over here. So we have these patients come 76 years old patients come to us, and we use PSMA imaging to identify he has a metastatic disease. There's close to 100 tumors around his body, and we based on this, we treat this patient with a 3 round of theranostic PSMA lutetium treatment, simple IV injection, and we achieve complete remission. The interesting part is because PSMA lutetium emit gamma rays, so we can monitor where the drug goes, and we can actually monitor the drug response along the time. One very interesting thing I want to mention to the audience over here is, well, this patient's PSA is 0.05. Traditional, when we see a patient with this many metastases, we'll think his PSA at least like a 30, 40, 80, or even over 100. But this patient's PSA is 0.05. And this case just tell us PSA is not reliable to evaluate tumor burden and aggressiveness progression of the prostate cancer. And also PSMA is a very efficient way, also can offer it's a very efficient tool to detect prostate cancers, even when patients' PSA is very, very low. And this is another case. Patient came to us in 2016. The conventional method cannot locate where tumors are, but we just know the patient has biochemical recurrence. So we do PSMA study, and we actually identified there's a metastasis around the lymph node in the lymph node around the abdominal area. So, but unfortunately, patients' doctors were not familiar with this new treatment at that time. So suggest patient to go back to receive conventional radiation and the hormone and chemotherapy. So a year later, when patient coming back, this is what we see. And the good news is the external beam radiation works. So you see the only area being irradiated is clean, but the cancers explode to everywhere in the body. So after 2 rounds of this type of trip, the lutetium therapy, we achieved complete remission over here. And this is some more unique severe case. This is a patient PSA achieved 1800. This is not a bone scan. This is later all the prostate cancer metastasized to the bone. And patients in severe pain, in hospice care, in morphine. Usually when we see this kind of case in clinic today, you will think the patient has maybe several weeks to a month to live. But we actually treat the patient, offer the patient several rounds of a PSMA treatment, and not only a year later, the patient is still alive, and the majority of lesion has disappeared, and PSA dropped from 1800 to around 10. And this is just another very unique case. Majority of his metastasis is actually in the liver, and rarely you see the prostate cancer with such severe liver metastasis. And again, PSA got to 1400. So PSMA images shows the lesions, and we decided to treat these patients with lutetium, and we got a very, very good result on liver lesions. Of course, there are still some bone lesions over here not being cleared, but this is significant non-invasive way to offer patient very, very good life quality and efficient to treat control of the soft tissue metastasis. And this is also another paper we published in 2020 to show using this lutetium PSMA, we can offer good control on lung metastasis too. And a lot of people ask, can this method be used for primary tumors? The answer is yes, but based on our experience, it's not quite ideal and not as efficient as distant metastasis. We do have some successful case using this method to significantly shrink the primary tumor, and again, it's not work on every patient, and it's not as efficient as treating metastasis tumors. And this just show you some of our data. Over like 70% of patients for this study, we see the PSA respond after the treatment, and we have about 5 to 10% of patients can achieve complete remission, and the rest of patients generally have maybe have a mixed type of progress, meaning some tumor shrink, some tumor grow bigger, and but usually they see a significant improve on symptoms and improvement on quality of life. And this is just some data we published. The median, the radiographic progression-free survival is 18 months, and median overall survival is 27 months, and the cohort is about 200 patients. I want to mention that because this data is from our early group of the patients, and majority of these type of patients, they are all in very, very bad shape. They have received failed on chemo, hormone, any current available treatment. That's how they come to our clinic and to receive this new treatment. And yet we still can achieve these kind of numbers. And what we have observed for the past few years is the patient can come earlier, and the response rate and the number is actually increasing. So this is just a plot to show you these are the survival benefits for current first line, second line hormone chemotherapy. The best drug can offer about 5 months of survival benefit, but it's about $10,000 a month. And for the data we just show you, we can offer ways a very significant improvement on survival of the patients from bad shape. So, but like what I said, the beta is not, lutetium is not the only solution. Sometimes the patient will outgrow our treatment, and sometimes the beta cannot suppress it. So right now we need to have a more stronger isotopes, which we want to use alpha. The reason we want to use alpha is can emit at least 100 times more energy than beta, and it has actually smaller range, around 5 cells, and so which will allow us to theoretically has better controls. And there we have tried different kind of alpha isotopes with the PSMA, but the most promising one would be actinium-225, and so that's why I want to share some data I want to share with you. And a lot of other groups have done actinium PSMA alpha treatment, and you see this data published in 2016. We see a significant progression, significant metastasis in abdominal area after 2 rounds of beta therapy. It still outgrow the beta treatment. So after throw in 2 rounds of alpha treatment, actinium-225 PSMA, and there is significant improvement on treatment. Another round of treatment almost achieved complete remission over here. It's a very dramatic result over here. And also this is another case being published. It's the significant bone metastasis. PSA got to almost 3,000, and after 4 rounds of treatment, achieved around almost achieved complete remission. This is just another case of severe bone metastasis after several rounds of alpha treatment, and we can get a complete remission. But the reason I share other people's case is one thing they're in common is, yes, they all offer very dramatic result and make people very exciting. But if you look at their salivary gland, almost to the end of the salivary gland of this kind of patient, they're all burned out. Because we mentioned salivary gland is actually the background organs, and if you throw very strong energy over there, it almost guarantee this patient will have a dry mouth over here, and that's a very unpleasant side effect for alpha therapy. So our group in 2018 started trying to figure out how to solve this problem. One thing we're trying to inject Botox to the main salivary gland on one side, and to leave the other side as a control. And so the goal is trying to temporarily paralyze the salivary gland with a Botox injection. So, and based on our PET image analysis, we can actually see there's significant decreased uptake of a PSMA on the side we inject Botox. I have to say the success rate is a very promising concept, but we're still trying to work hard to optimize the procedures, and we're trying to explore other more non-injection needed method in order to decrease this salivary gland uptake. So another method trying to decrease the salivary gland toxicity is trying to decrease the quantity of alpha particles we inject into the patients. If you think carefully, beta emitters, lutetium-177 PSMA, can offer good control to the patient, to the cancer, but not aggressive one. But we don't observe any toxicity or minor toxicity. But alpha treatment will have a good control over the treatment, but it will not offer, will bring you very severe toxicity in salivary gland. And can we just combine both of them? And so we can have good control and also less toxicity. And that's the logic we have over here. And that's why we are trying something called tandem treatment. So we have a patient over here, PSMA image. We give after 3 rounds of the beta treatment, the disease still in progress. So instead of giving this patient alpha therapy, we give them tandem therapy, meaning combine alpha and beta together. And we have a very dramatic result. Is one round of tandem therapy, we achieve complete remission just from this status to this. And this is not the only case we see over here. And then we have another case is, again, failed on lutetium beta therapy, and one round of tandem therapy, we achieved almost a complete remission over here. And this is a very interesting phenomenon, and the mechanism behind it, we still hope to explore more and to do more research on that. So this is just trying to show you some interesting observation we see on clinic. So what about the future? What's important? In order to reach those precision medicine, we need to know what's the dose we gave it to every single tumors. So dosimetry is very, very important for this new type of treatment. However, this type of dosimetry is very different from conventional external beam radiation dosimetry, because the radioisotope keeps circulating in the body, and there's a biological mechanism involved into it. So in order to develop a brand new method to evaluate the dosimetry is very important. The past few years, we developed some method to use SPECT to scan patients in different kind of time point, and come out with some formula to calculate the dose, absorbed dose for each tumors. And this is some of our result. Based on some of our result over here, we actually can deliver the very significant dose to each single tumors. It's not homogeneous. You can see some tumors can achieve to like almost 500 grays, and some tumors only achieve like a 38 grays. And this is a really amazing numbers, which is aligned with what has been published by other groups. This just explain why this kind of treatment can offer such a good control of the tumor, because we can deliver a huge amount of dose, way more than enough dose to each single tumors without hurting surrounding tissues. And in order to know this, we also can predict which tumor may not get enough dose, and we will need to keep a closer watch and maybe to do the second round of treatment. And of course, this type of, once we start have the volume with a lot of patients receive this, and each patient have hundreds of tumors, we just cannot do it manually. So the only way to achieve this is we need to develop the AI algorithms on that. And this is some prototype of the AI algorithm our group has developed. Is at the first beginning is be able to evaluate analysis the PET-CT, PSMA PET-CT images, and automatically generated the report to tell where the doctors where the tumors are, and understand the SUV and also the risk factor, volume and risk factors. And then the next phase is trying to using this as an anchor to develop the more automatic dosimetry software to facilitate this process. And I just want to show this is a prototype, and the goal is trying to make it more interactive with doctors. So we use a different kind of color to label it. For example, the computer know, oh, kidney is hot, but it's totally normal. So the label is green, and they say, hey, there are 3 little lesions in the liver. It's easy to be ignored. The contrast is not high, but it's definitely are tumors. So label are red. So doctor will not miss it. And there's something in the spleen, computer doesn't know what is that. And computer need doctors go there to confirm that. So it labeled as spleen, as a splint. So this is just to show in the future, the concept is the doctor need, we can acquire way more information from the cutting edge technology in order to improve really harnessing the power of the data hidden behind the information we have, turn it into useful intelligence. Then we need to start build a new mindset is doctor working closely with the computer or with the machines, and to improve the work efficiency to offer the patient the best care. So I just, and in the future, once we can achieve this, and it's going to be multidisciplinary work. A lot of people say, oh, is this going to be the, once we have this, do we still need a radiation oncologist? Do we still need the oncologist? We definitely need it. This is just another tool, and this is a powerful tool, but this is not an ultimate tool. So, I just want to show you some of our patients over here, and to show how when we work with each other with different kind of for people from different with multidisciplinary collaborations, we can offer a very good result for patients. So this is our patient from West Michigan. Gleason 7 has prostatectomy, PSAs are rising, and of course, conventional technology cannot see, CT/MR cannot see where tumors are. So we offer the PSMA treatment over here, and that's what we found. We found the 3 tiny tumors around the patients. And with these patients with 3 tiny tumors over here, and based on the information, we just say, hey, even you have PSMA avid tumor, but we don't think you need to receive an unnecessary dose for that. We can easily use other method to tackle this kind of method. So our treatment strategy is using the cyber knife to irradiate these lymph node metastasis, and using a surgical outpatient surgical procedures to remove the perineum lesions from the patients. And you can see there's a lesions in the pubic bone, and we use a worker with Dr. Mancini using the cyber knife to take those lesion out. So after the cross-discipline collaboration, the patient's PSA dropped back to say lower level, and we're keeping watching this patient's progress. And this is another very unique case. That is a dentist from San Diego. And once he got diagnosed with prostate cancer, he just refused to receive any hormone and chemotherapy. So he's one of the early adapter to do went to Germany to do the PSMA treatment and to do several rounds of the PSMA treatment. As you can see, his disease is going on and off, and there's small lesions, metastasis going down, but this kind of big primary tumor still keep over there. But after 4 rounds of treatment, we start to take a very interesting step, because we think every marker shows his disease is pretty stable. So we stop, even we can see the tumors over here, we stop treating him, just being there to watch it. Every tumor, the tumor he has doesn't affect his life quality, and we think there's no reason to keep hitting it as long as we can catch it, the cancer coming back in the earliest phase with the PET technology. So after almost 8 months of not treating, not working with these patients, not treating this patient with any method at all, the tumor doesn't really grow, and the PSA increased, but visually the tumor doesn't really grow. But we don't see any distant metastasis. So this time we say, hey, let's give a 5th round of radiation therapy to try to take this lesion out, and then let's go work with the proton therapy center to take these big lesions out. And after the proton therapy, you can see this patient, even PSA is still high, but on PSMA wise, he achieved kind of a complete remission right over there. And the result lasts for a very significant period of time. So another interesting type is, we all know the neuroendocrine type of prostate cancer is a big problem to us. It's pretty much, there's nothing we can do about it. But using theranostic method, this just opened a brand new way, allowed us to explore. So this is the project we collaborate with the Beijing University. So we all know, like right now, there's available theranostic tracer targeting neuroendocrine tumor. This drug is targeting somatostatin receptors. So basically, we have these patients, prostate cancer end stage, and being identified as neuroendocrine type of differentiation. So we say, hey, why don't we try to using this treated this as a neuroendocrine tumor? So we imaged these patients with gallium-68 dotatat, which is a corresponding tracer for neuroendocrine tumor theranostics. And we identify and confirm the tumors of these patients have the expression of the target that we can hit. And we give the patients, therefore we give these patients 2 rounds of the lutetium dotatat to just burn it out. And we actually achieve the complete remission on those kind of lesions. And the interesting part is now the PSA start drop, and also the patients start to respond to like a PSMA treatment and also hormone therapy again. So this is just a one case, but it's a very, very interesting case, show us some clue worth for us to explore more. So we can use molecular imaging to guide us what kind of molecular target we have on each tumor, and then we can use the corresponding the bomb to burn it out. So the question is, so if we see a high avid and intense PSMA images, does that mean this patient is a good PSMA treatment patient candidate? The answer is no, especially for severe patients. And what we figure out is we still sometimes, especially for late stage patients, severe patients, even they have a high PSMA expression, we still need to do FDG images to confirm they don't have extra tumor over there. Because based on the prostate cancer biology, a lot of the cancer in the end stage can actually differentiate into the non-PSMA express prostate cancer. So this is just show you an example from the paper. And this patient has a very high expression PSMA over his body. But the tricky part is when you do FDG images, you show a lot of tumors in the liver area, and which doesn't show some PSMA. That means even we can burn all these PSMA avid lesions out, we still cannot solve the liver problems, and these can be very, very lethal to the patients. So when we combine these two information together, we will say this is not a good candidate for PSMA treatment for these patients. So can this cure, can the result last? So I want to show you one of our patients. Come in 2016, 3 rounds of treatment, and in October 2016 achieved complete remission. Every year come back for follow-up. Still remain complete remission. This August or October, when he come back for follow-up, if he still remain complete remission, which we believe that he will, and this may be the world first cured patients from PSMA treatment. And I want to mention this patient's an internist, and again, he refused to receive any chemo or hormone therapy. So the only treatment he received is lutetium PSMA treatment. And so right now we can have more sensitive data. Can we improve the resolution? Can we see better? So because we can hit the small targets. So knowing where the targets are is very important. So I want to start to introduce a new concept. There's a new PET scanner coming out called whole body PET, and it will offer 40 times more sensitivities than conventional PET scanners. And therefore, because of the physics, it can achieve very, very high resolution. So with this new machine, not only we don't need to do those kind of eye to thigh scan anymore, just assume there's no tumor grow outside of this range, but also we're going to have a chance to see micromillimeter metastasis. Again, these lesions will show up on the imaging with a micromillimeter size. I just say the micromillimeter size lesions may have strong enough signal to be shown on these kind of new imaging scanners. And in order to do that, we cannot just rely on imaging to treat the patients. We need to start combining all the genomic, proteomic informations, and then computer process that to allowed us to know who is the better candidate. Because we, based on our experience, we see super responder, the one shot, 100 tumor disappear, and we also see non-responders. And why some people are super responders, some are not, some people are in between. We need to do more comprehensive studies so we can offer a very strong, more precise treatment to the patients. In the future, the prostate cancer, I foresee a lot of a conventional method, like a PSA test will still remain, it still offer the useful information. Biopsy may be partially replaced or being replaced by liquid biopsy. And the CT/MR bone scan, FDG scan may be replaced by PSMA because it's a one-stop shop, at least from the first diagnosis phase. And then after acquire this information, we can offer the patients more sophisticated, targeted, precise treatment, all the way from surgery, different type of radiation, and targeted treatment. And what we are trying to achieve is, with this method, we can right now really can start think about same-day diagnosis to treatment. And that's what BAMF is trying to do. I mean, when patients come in, we just need to put an IV portal to the patients and draw all the blood needed for liquid biopsy and a lab test, and using the same IV portal, inject the PSMA tracer in, and then the blood send it into the lab, and the patient send it to a scanner, and all the data send it to our AI servers, and then the data was sent back to the doctor's iPad, and doctor will use the information to judge if this is the right patient for a PSMA treatment. If this is the right candidate, then using the same IV portal, we can directly inject the therapeutic treatment to the patients, and 4 to 6 hours later, patient can go home. So this with all the technology we have built and available right now, this is not a dream anymore. This can happen in a very short years. We're building a brand new clinic dedicated for this in Grand Rapids, Michigan, partner with Michigan State University. So we're going to have a radio pharmacy to develop a wide variety of the novel tracers for both diagnosis and treatment, and with the molecular imaging clinic equipped with a whole body PET and a PET MR. And we're gonna have a theranostic clinic equipped with digital SPECT CT. And the idea is to keep exploring and to push the envelope to learn more about how to use this treatment more efficiently. And this is the photo taken a few weeks ago. And this is just another view of the building, and this is a view from a few weeks ago. So the conclusion is PSMA will literally change the diagnosis and treatment of prostate cancer. We really need to do a lot of research to think about how to make this treatment more efficient, how to combine with external beam radiation, immunotherapy, and other targeted treatment, and how to allow us to achieve precision medicine, decrease toxicity. And we really want to start thinking about the apples-couple effect, because we start to see those kind of super responder we see. We are thinking we may accidentally induce some apples-couple effect over there, but that's just taking more research to understand. And again, because this is very useful technology, it takes new infrastructures for efficiently treatment to the patients. And we need more radiopharmaceuticals and for other type of cancers. So I want to appreciate our team from Bad Berka, Dr. Tsai, Dr. Bukani, and Dr. Bong. And thank you, and I'm open for any questions.
Awesome. Well, thank you so much for all your time and outstanding information. I think we're up against a time deadline a little bit, and just for respect out of everyone's afternoon, if you don't mind emailing me the questions, and I can reach out to Anthony and kind of get those answered. I put my email in the chat on the right. And I think just outside of your clinic, Anthony, what do you think as far as the timeline for adoption more diffusely throughout the United States, which is obviously kind of behind a little bit compared to Germany and Australia and so forth?
No, I think the adoption in the United States can be very, very soon. there's very exciting news just published 2 days ago by Novartis. And the phase 3 clinical trial of the PSMA treatment has a very promising result. And there's several clinical trials has been started in big medical center like UCLA, like Memorial Sloan Kettering. So I foresee in the coming 2 years, this technology will be available in United States, but just gonna be in a smaller scale. And the reason I said in the smaller scale is that we just don't have these kind of infrastructures. Infrastructure means several things. Number one, we don't have the manufacture facility allowed us to manufacture this kind of therapeutic tracer in commercial scale and a whole supply chain over there. Number two, we don't have doctors, enough doctors to really know how to administer this kind of a treatment. So we need to have a more intensive training and educational program in position so we can train more doctors to adopt these technologies. And number three is the place to treat the patients, because these are radioactive drugs. You cannot just build another infusion center and treat the patients. So it takes special regulatory radiation safety concern to design this facility. So that's why I mentioned in the end of the conclusion, the infrastructure is very, very important to adopt this technology. So I think it takes everybody in every field to work with each other in order to make it happen, available to the patient who need it.
Absolutely. Good. Well, a virtual round of applause for your time and effort, and thank you for kind of opening our eyes and ears into everything that's been going on with your research and studies, and we appreciate your time very much. So we'll end it there and hope everyone has a great day.
Really appreciate this opportunity. Thank you.
Thank you.